Hey everybody, welcome to a brand new year here on Hail State Debate, a brand new year for you in public forum debate. Welcome back. It's an unusual circumstance for us all. If you are debating, and if you're here, I guess you are, you're probably doing it virtually, but that doesn't mean it's any less competitive. So we're back to do what we always do, which is to try to provide analysis of high school debate resolutions in a way that is both useful and accessible for people all across the country. We kind of try, if you haven't seen the channel before, to blend a sort of real world analysis with also kind of an understanding of how debate works. My name is Brett Harvey. I'm the coach of the team here at Mississippi State, and this is Mia Robertson, our ace debater. I have to say now, I get to brag on her, the season-long national champion of IPDA, so she's super qualified, and we're very, very grateful to have her here with us. And we are here to talk about the September-October resolution for public forum debate, which has resolved the United States federal government should enact the Medicare-For-All Act of 2019. Overall, generally, I think it's a pretty balanced topic. It has some interesting facets to it that we're going to talk about in just a second. On a scale of 1 to 10, I'd say it's probably an 8. It may be a little much for the first resolution of the year, but I think it's certainly doable. Your thoughts?
I'm also giving it an 8. I think it'll allow for some pretty nice debates on this topic, especially since they haven't just chosen the umbrella term like a single-payer Medicare system or a Medicare-for-all system, that they've actually given you a clear-cut bill that you're debating. I think it's going to make this round a little bit cleaner, a little bit nicer. So.
Yeah, I think that was probably necessary. I think it'd turn into kind of a weird policy debate if you had to pick between all of them. But at any rate, same as we always do, we want this to be useful to you. So we're going to put the links to all the sources that we cite down in the notes below. We're going to put timestamps to all the different sections, so hopefully those will be useful to you. You can always follow us on Twitter at Hail State Debate for sort of our general thoughts on debates and topics and kind of the world in general. And hey, if this is useful, maybe subscribe, maybe tell a friend. We always want to help as many people as we possibly can. So the basic order for this episode, I guess, will be we're going to do, as usual, our initial thoughts, talk a little bit about the framework of the debate, then move on to have kind of a rundown of exactly what the Medicare-For-All Act is. I think it merits its own kind of discussion because it's going to obviously be central to the entire 2-month topic. So we'll spend some time on that. Then we'll do pro arguments, then con arguments, and then final thoughts. So with that, I guess we are in line for some sort of opening overview thoughts on the topic. And Mia, I will defer to you. What do you think?
Great, I'll start it off. I think, okay, one thing we really need to just knock out right out of the gate, this is an absolute monster of a bill. And if any of you debated the topic on the Convention of the Law of the Sea, you know that debates with these absolute monstrous documents, it's very, very easy to devolve into really messy, really just muddied water debates on specific articles and things like that. So I think that a lot of the people who are going to be able to win rounds on this topic are those who can just bring it back down to the real world and make it a little bit simple for your judge and kind of just clear up what's in their mind. Because if you're throwing out a million different articles, yes, that's going to be necessary, but the good debaters, the ones who are going to take home wins, are going to be the ones who can make it very, very clear to the judge and bring it back down to earth.
It's 120 pages, folks. I mean, this is a massive, massive document.
Yeah, and also, very much like the charter schools topic at NSDA last year, you're going to really need to make sure that you and your opponents are speaking the same language on terms of metrics. So there's a million different metrics by which you can measure a healthcare system and an efficient healthcare system and one that's very good. So you need to make sure that you're providing a great metric, specifically within your impacts, that you're weighing against your opponents and that you're not just dismissing their metrics outright. You're specifically saying the metric by which I measure this healthcare system is better than my opponent's because it's the people who can make it very simple and say, my opponent has talked to you a lot about how costs are going to go down for people, but does that really matter if they have to dip into private insurance anyway? It's people who can make those very simple weighing statements and dismiss their opponent's key metrics.
I think, the basic metrics that you're going to be looking at on this topic are things like, the number of people covered, obviously, the number of people not covered, the cost to the government, the cost to society as a whole, like as part of GDP, questions of efficiency, lives saved potentially might be the ultimate metric that you look to. And then, depending on how nuanced the debate gets, depending on how specific and in the weeds you get, you could be talking about things as specific as like efficiency, how long it takes us to implement it, how reliable it will be going forward, how sturdy and stable it will be. And so there are a million different things, as Mia says, and if they're just ships crossing in the night and you're not explaining why, you look, at the end of the day, a few dollars saved doesn't matter if we have 30 million more people who didn't have coverage covered. Those kind of explanations, those meta explanations will be important. I completely agree. My thoughts are very similar, and the first one is that it is unusual for debate resolutions to directly incorporate very specific pieces of legislation, right? Normally what they do is they describe something like, we should reduce the deficit, right? But in this case, as Mia mentioned with a few years back, the law of the sea treaty, it has a very specific legal document. This is a 120-page bill, right? It's extremely complicated. And the way I explain this to debaters, like when they see topics like this in college, is when you have a resolution that incorporates a specific piece of legislation and it's a 120-page bill, it's almost like having a 120-page resolution, right? And later on in the video, we're going to talk about like exactly how much of this lengthy, complicated bill with all these details is the pro really responsible for defending. Do you have to defend every word of it, every little jot, every detail, or do you just have to sort of defend the basic big principles of it? And this is, kind of an important question to answer. And there are going to be some theoretical issues we'll talk about with that later on when we talk about framework, about like exactly how specific you have to be. And I think it's important to be aware of that. And especially when you're on the pro, I think you need to be conscious and spend as much time as you can really understanding this bill and at least understanding what the details are, if not having a pre-written block on every single section. But being conversant, you don't want to be caught flat-footed and be like, did you know this was in the bill? Like, no, I had no idea, right?
Yeah.
That's somewhere you don't want to be, right?
Any debater worth their salt is probably going to be bringing up very specific sections of this bill. And as the pro, you either need to be prepared to read every single page of this bill and respond to every single argument against pages of that bill, or you have to have a very simple argument about why you don't have to defend every single word of that bill. So either one of those things will work, but you have to be prepared to do one.
Those are my initial thoughts. Is that everything from you?
That covers it.
Fantastic. So with that, what we will do is we will come back and start talking a little bit about how to frame this kind of monster of a resolution in just 1 second. Okay, so framing the debate. Now you might think on a resolution that has a very specific bill, that definitions and framing wouldn't be that difficult. We don't typically read a lot of definitions in public forum. You probably don't necessarily need to read one here. Hopefully everybody understands. But you give away some complexity by using a specific bill, but then you bring some back in, and we're going to talk about how that works in just a second. But before we do that, there's one real important caveat, and we kind of assume everybody knows this, but we want to make sure we're explicit about it. So.
Yes, do not confuse the general idea of Medicare for All with the resolution that we're talking about today. We're talking about a very specific piece of legislation, and that is the Medicare-For-All Act of 2019, which was introduced to the House by Representative Jay Appel. This is a very specific piece of legislation, and I know that oftentimes Medicare for All is used as this big umbrella term. That was all too clear in the last election cycle. It can mean a million different things. It can mean that we have a public system competing with a private one that people can opt in and buy into. This is absolutely not that. So make sure that you're not confusing these umbrella terms with the specific legislation that we're debating on this resolution.
And that's important, not just in like, hey, don't like just completely go into the round and not know this. It's also important in specific research, right? So if you're going out and you're researching how much will Medicare for All cost, right? And, and you pull up an estimate that's X, and it's talking about, a plan where it's a public option, right, or it's a buy-in. Well, that's fundamentally different than what we're going to be doing. It's different by orders of magnitude. And if you go in with a cost estimate for, the Pete Buttigieg version of like Medicare for All or something along those lines, or even the Andrew Yang version of Medicare for All, that's going to be a different number. And a really good opponent is going to say, wait, what was your source on that? Which Medicare for All bill were they talking about there? It wasn't the Medicare for All Act of 2019, it was a different one. Now, that's going to be a really good opponent that has that, but if you go in and all of your cost estimates are based on a different piece of legislation, that's going to be, a really, really not fun round for you.
Yeah.
So make sure that as you do your research, just because it has Medicare for All, we're going to talk later about how Medicare for All is kind of like a brand. It's like, super happy fun time, right? It's a term we use to describe something because people like Medicare, right? But, and we'll talk about that in just a minute, but make sure that either A, the statistics you're getting are generic enough that they're at least saying, well, this could be any number of Medicare for All, and you're ready to defend that, or B, it's about this specific bill, because otherwise it could get really rocky really fast. So the other question is, and I talked about this earlier in the intro, like exactly how much of this bill do you have to defend? And in a minute, we're going to talk about like the different characteristics, like number one, it replaces all the existing programs. Number two, it's not an option, it's mandatory for everybody. Number three, it's going to outlaw most private insurance that duplicates things and all these other basic sort of pillars of the law. I think it's pretty clear that the pro has to defend all those major things, but one question would be like, does the pro have to defend every little detail? Or alternatively, can the pro say, look, I don't have to defend every single word of this. They could amend the bill later. Little details could be changed if there's a typo, if the lead-in period is not long enough. Those things don't matter. And we could spend a lot of time on framework and debate theory. I think the simplest answer to that is basically, we're not in Congress here, right? We're in a debate round. And so the theoretical answer would be like in Congress, right, you could go back and amend these things out of it. But what we have for the judge here, and this is kind of the debate theory framing of it, is the judge is presented with a binary choice, right? They have the bill as it currently exists, and you go obviously pull a copy of it off of the congressional website, right? And they can either vote it in or out. That's the only choice they have. It's like they're sort of imaginary policymaker, and in this round they do it or they don't. So I actually do think, as you mentioned earlier, sort of alluded to, I do think the pro is on the hook for all the little details, like the pharmaceutical provisions, and why are we going to have a 2-year ramp-up period as opposed to a 4-year ramp-up period, like in the Sanders provision? I think what the pro has to say, though, is not, hey, I don't have to defend every part of it. It's like, yes, there are some downsides to it, but if you have to make a yes or no choice, doing something to get people insured and to cut costs is worth it, right? We should do it even though it's not perfect. Don't make the perfect the enemy of the good, as I like to say a lot, right? And in the future, maybe we could go back and amend some flaws out of it, but I don't think the judge can fiat that. I don't think the judge can just ignore the problems, which is why, as Mia says, I do think the pro needs to spend some time becoming very familiar with little details of this. So, we could dive more deeply, and I'm sure if this were Lincoln Douglas or policy, we might see some really deep theory arguments on this, but I don't see a way of dodging those things.
Yeah, this is kind of where pro has to kind of exploit that general idea that con can't propose counterplans. They say, look, judge, it's this bill or nothing. So as the pro, if I can prove to you that a world in which we pass this bill, flawed as it may be, is better than one in which we don't, then I win the round. It's like Brett says, it's not making the perfect the enemy of the good. And it's also asking a very simple question to the con. It's, con, are these small, marginal, esoteric details that you bring up in the bill worth throwing the entire bill out completely? And if they can't prove to you why it's worth getting rid of the entire bill and not passing it, then pro can easily win that round.
Yeah, I think as a pro, I have a spiel ready for that, which is I read my big impacts, like we'll get 30 million more people insured, we'll save X trillion dollars, we'll have fewer deaths, whatever. And I say, look, I freely acknowledge that we might have some problems in the patent, the patent issues that need to be outlined, but they in no way outweigh this. I'm not even going to fight over that. I'm not going to even, you might be really good and no, but if you don't, as Mia said, you need to have a backup that says, I can't fight over every detail, but having 30 million more people insured is worth having a few problems. Like when we passed Medicare to begin with, when we passed Social Security, when we passed the Affordable Care Act, when we passed every major piece of legislation, all of them had details and problems. If we only pass perfect legislation, then we don't pass legislation, right? Absolutely. It's basically the message. But as you pointed out, that does lead to another question, which is, since the pro is on the hook for this and gets to use this very elaborate plan, right? What is the status of the con, doing the same? Again, now we talked about this earlier. The rule in public forum debate from the NSDA says you can't use plans or counterplans in public forum, and it defines a plan or counterplan. It defines them both as the same thing, right? It says they are both a formalized, comprehensive proposal for implementation. Well, I don't know about you, but I'm pretty comfortable saying that a 120-page bill that's been entered into the U.S. Congress is a, what's the term? Formalized, comprehensive proposal for implementation. That's kind of what a bill is. So the NSDA has basically told the pro on this, I don't know how to frame this, but like that rule just doesn't apply to you because you are absolutely going to have to run a plan. Not only may you, but you must. And so I think one of the things the con can say is, if the pro is able to have a specific 120-page bill and somehow, I don't know how this could be the case, but somehow that's not a plan, then I also get to look to the Bernie Sanders 2017 bill. No, don't get confused. Sanders introduced the Senate version of this in 2019, but he had a different bill in 17, and there are many other alternatives. But you just say, I should be able to introduce an alternative. Why would the con want to do this? Well, there's a couple of reasons. Right. First of all, I think in the context of this resolution, the con has a strong argument that this is how the real world debate works. Right? There aren't a whole lot of people who think that the healthcare system in the United States is perfect and don't want to reform it. So it's really challenging for the con to say the only thing I can defend is the status quo. Right? Number two, it's a fairness issue. If the pro has been allowed to have this very elaborate bill with all these, these backups and methods and metrics and things that it can use, then I should be allowed to do the same thing, especially since in the rule itself, plan and counterplan have the same definition, right? So, I think the message, I'm not saying you have to do this. If you're the con, you can absolutely, if you want to, run a case about why the status quo is good and we should just not do this. And if you don't want to wade into this territory, depending on where you debate, I understand. But one of the things that I might be prepared to say to the judge is, yes, I'm absolutely going to advocate for an alternative because that's how the real world debate works. And if they can advocate for a 120-page bill that would take up like half of the entire federal budget, right? And if that doesn't violate the rule against plans, then I also can advocate for a bill, and that shouldn't violate the rule against counterplans. Fair is fair. And what that allows you to do is, instead of it being do something versus do nothing, it dramatically narrows the debate to the very particular areas of how. Like all of their impacts as the pro can go away. Like they say, we're going to cover 30 million more people. You're like, awesome, me too, right? That's not the question. The question is, do we have a small copay? And then you turn the whole debate into a question about whether or not to have a copay, or whether or not to, cover people who are in the country with, undocumented immigrants, or just whatever you want to cover, right? Or whether to have a buy-in or something along those lines, and you reframe it as the conflict you want to have. So I think it's a really, really interesting question, and I think, frankly, NSD has kind of put you in a little bit of a sticky wicket by mandating a plan, and then can you run a counterplan? So that's the question.
Yeah. Again, be ready to defend that counterplan, but as Brett says, it gives you a lot of ground and a lot of opportunity to turn all of their impacts against them and say, I get all of those impacts too, I just get them in a more efficient way, or I get them in 4 years rather than 2, or we can implement this more efficiently, something like that.
Yep.
So we've talked a lot about this act. Let's finally get into the summary of it and talk about exactly what the Medicare-For-All Act of 2019 does.
All right, so at long last, it's now finally time to start talking about like what the Medicare-For-All Act of 2019 actually does, and we're going to break down the sort of basic pillars, the main elements of it that you need to know. This is not an exhaustive summary, it can't be. We will try to link to some really good sort of relatively brief summaries that go into more depth than this, but this is just going to be the main pillars, so we will kick it off, and Mia, just take us through the basic elements of it.
Yeah, so on the most basic level, the Medicare-For-All Act of 2019 would provide single-payer health care coverage to all U.S. residents, not just those over 65. So this is incredibly different from the current Medicare system. Medicare system as it stands is a single-payer medical insurance program that provides federally funded coverage to people over the age of 65. And the reasoning is very simple and it's very rational. Basically, whenever it was adopted, the idea was that as you get older, you have more expensive healthcare needs, so private insurance becomes impractical. So you need something else. You need something more dependable that older Americans can focus on. So that was basically the logic behind it to begin with. And of course, doctors and hospitals voluntarily chose to opt in and to be participating providers to accept payment rates from Medicare patients. Now, the Medicare-For-All Act of 2019 is a little bit different, and that is in that what is covered under this bill is very different than what is covered under Medicare as it stands today. It outlines those things a little bit later in the bill, and we'll get onto that soon. So you may be asking yourself, if it covers completely different things and different people are going to be covered by it, obviously all residents in the United States, why are we calling it Medicare? Well, like Brett said earlier, Medicare is a very trendy term and everyone wants it on their list of policy proposals. So of course we're calling it Medicare for All, but let's not get it confused. Medicare, what it covers is very different than what the Medicare-For-All Act of 2019 is covering.
And this is important in terms of your research because I think we'll pop up a visual somewhere that shows the list of the things that are covered on Medicare for All, and it is not dramatically, but significantly broader than what is currently covered by Medicare. There are benefits that have been added, and we'll try to summarize those in visuals and in some things that we link to, but you'll see that there's more to it. And so when, for example, one thing you would want to avoid is going out, normally I would tell you that researching like X and then extrapolating it to Y is usually a pretty good strategy, but if you go out and research like, you know, Medicare costs X dollars per person, and if we multiply that times the additional number of people, that would be a really bad strategy, because Medicare for All is not actually Medicare for All. It is a new, more expansive health coverage program, and it's called Medicare because statistically, if you look at polling, people like Medicare, so that's a good brand to apply to it, right? So you have to be very, very careful about what you're actually researching.
Yeah, so the idea of this, basically, how do we achieve this, is basically that we'll fund this through the appropriations that we would have otherwise been spending on other programs like Medicaid, Medicare as it exists right now, and a dozen other federal programs that we're spending a lot of money on. So basically they're saying we're going to put everyone on Medicare and not on these other things, so we're not going to be spending money on those. And this is basically called the Universal Medicare Trust Fund, and there are a number of things that they're taking appropriations from. Huge list, I'll name a couple of them: the TRICARE program, the maternal and child health program, vocational rehabilitation programs, etc. But as we're going to talk about later, this won't be even remotely enough to pay for Medicare for 330 million Americans, and we're going to get to that a little bit later.
Yeah, and so if you want to see the sections of the bill where it kind of talks about the trust fund, look at sections 601 and 701. And by the way, note here, you know, knowing these sections is going to be a part of debating this bill. Like, you need to know if we're talking about, you know, where the trust fund comes from, that's going to be in sections 601 and 701, right? I know that's a burden, but if you want to do really well, being familiar with the major sections and what's in them is going to be part of it. So just be aware of that. But yes, Mia's right. If you take all of these things and put them together, they're still nowhere close to what you're going to need to fund the bill. And we're going to have a long discussion, really on the con side mostly, about like, where's the money going to come from? So.
Yeah, so we've said that the Medicare-For-All Act of 2019 encompasses giving Medicare to all people, not just those over the age of 65. So who exactly is eligible? Well, the bill says in section 102 that every individual who is a resident of the United States is eligible for Medicare for All. Not every citizen, not every lawful resident, just every resident. So of course this is going to create a little bit of hazards in your debate. Is this either going to lead to massive strains on our already strained healthcare system, or is it going to lead to immense cutbacks on immigration? Because obviously we already don't have enough money to fund 330 million Americans getting Medicare for All. So what kind of strain on our resources is that going to be? That's definitely going to come up in your rounds.
Yeah, if you create a system where a person can get free medical care for their sick child or their sick spouse by coming to the United States, lawfully or unlawfully, I mean, who could ever blame a person for doing that, even unlawfully? I mean, but the question is not whether they're a good or bad person, and we're going to talk about that later about being sensitive. It's just whether the system can handle creating a magnet like that. Now, one thing people might say on this is if you look at Section 102A, the bill does give the Secretary of Health and Human Services, and by the way, the Secretary of Health and Human Services is going to become like God under this bill. I mean, the Secretary of Health and Human Services, whoever that is going to basically control like half the economy, well not half, but like a quarter of the economy of the United States. So that may be its own argument, like one appointed bureaucrat, you know, is going to have incredible power. But the Secretary of Health and Human Services can promulgate regulations to restrict who can be eligible, but they can only restrict it for people who come to the United States, who travel to the United States solely for the purpose or for the sole purpose of obtaining health care. So this would be like, you can't be in Canada, or Canada actually has it, but you can't be in like Mexico or something and come to the United States just to get medical care. But for the sole purpose, right, that's a really limiting restriction. Most people who come to the United States as immigrants, legally, illegally, whatever you want, right, don't come for the sole purpose. They might come to have a better job, to be with family, to send money back to their relatives, whatever. So it really is, if people try to say, well, you can have regulations that prevent this from happening, no, you can't. What you can have is regulations that stop medical tourism, right? In other words, you come here just to get a surgery done and then have Medicare for All pay for it. But if you actually come here and live, lawfully, unlawfully, documented, undocumented, you're in, right? And again, not because those are bad folks, not because we have a problem with them as people, but because of the strain on the system. We're going to have to talk about that later, right? So the question then becomes, like we talked about earlier, you know, how exactly would the care be paid for, right? So we talked earlier about where the money is going to come from, or the fact that we're not sure where the money is going to come from, right? The question is, how will the care be paid for? And the answer is 100% entirely by the government, right? So right now under if your parents have, health insurance, the way it works is the health insurance is going to pay for most of the cost of medical care, but you're also going to pay some out of pocket, right? You have things called deductibles, which is the amount you pay in a year before, the insurance kicked in, right? You have co-pays, which is how much you're going to pay for any given visit, like you pay $25 for every doctor visit or something like that if you have good insurance, and then the rest of it's covered by your insurance company. Under this bill, Section 202A completely bars out-of-pocket expenses. With a very few, tiny number of exceptions for most types of care, you're going to be getting rid of deductibles, co-insurance, co-payments, and other similar charges. It's going to be 100% out of pocket. And as we're going to talk about later, this is not something that is done at this level anywhere. Like the British National Health Service is sort of famous for being like free at the point of use. You go in and it's free. But even in reality, even the National Health Service in Britain, as we're going to talk about later when we talk about the con, is not free at the point of use. There are out-of-pocket payments. And this is a really controversial part of the bill, I think. Cost sharing through copays and deductibles is not just designed to bear part of the cost of insurance. It's also designed to kind of keep a check on how much medical care you use. Right, and one of the big fears about any kind of national insurance system is the idea that, if it's free to you, you're not going to govern how much you use. And so having a copay, like having to pay $25 every time you go, helps you decide, is this serious enough to go to the doctor? And what it does is it serves to push down use and get rid of like frivolous use of the medical care system. And that actually ties in, it all ties together, obviously it's one bill, but it ties in to the next very controversial part, which is that most private insurance would be made unlawful. It would be made illegal under Medicare-For-All. So under many healthcare systems, like for example, again, look to the British National Health Service, you can go out and buy or have your employer provide as like a perk a supplemental private insurance plan, right? And these things will they'll pay for things that aren't covered by the National Health Service or by the government, right? They might pay additional amounts to help get you in the door faster, right? And most of those things are going to be unlawful under Medicare-For-All, specifically any coverage that duplicates what Medicare-For-All does, right? So in other words, your employer cannot give you special coverage that like pays the doctor twice as much to get you in faster. Now, if it doesn't duplicate it, if it's for something that's not covered by MFA, right, then like cosmetic surgery, right? Could you get insurance for cosmetic surgery? I mean, I guess you could. I don't know like how that would work, but I mean, in theory, you could. And for like experimental treatments, like drugs that have not been proven, but you want to try it because it might save your life, could you in theory have that? Yes, you could. But those are going to be very, very small sectors of the insurance sector in this country. So the impact is going to be that the vast majority of private insurance is going to disappear overnight, right? What's that going to mean? Well, millions of people are employed by insurance companies. I know that's not a good reason to not reform healthcare because they need to make profits, but let's be real, there's going to be massive disruption here. Every major health insurance company is going to either go out of business or it's going to dramatically scale back to just a tiny handful of policies, and so that's a big deal.
Yeah, and on that, there are plenty of single-payer proposals that allow for a slow and steady turnaround so we don't have that fallout.
Yeah.
This bill doesn't. We're only given two years for a turnaround. So you're going to see all of those effects he's talking about. That's not some doomsday thing. That's legitimately what will happen because we're not given any time to implement this.
And that's one thing that Con can say is like, because there are alternatives, yes, we agree that in 10 years we should not have a private insurance sector in the United States. But if we do it in 2 years, we're going to be dropping an atomic bomb in the middle of millions of families in terms of their finances. We need to be more gradual about this. In other words, we would do everything you suggest, but let's do a different alternative bill like the Sanders bill and do it more slowly, right? And another thing about this is abolishing private insurance is not popular, right? Medicare-For-All as a brand, when you poll it, is very popular. So, but 58% of Americans support universal coverage. This is not Medicare-For-All, but for example, if you look at the polling, if you look at, this is from the Hill, a Hill-Harris poll in 2019, it says that 58% of Americans support universal, quote, universal coverage with either a private opt-out or private supplement, right, which is similar to what the Affordable Care Act currently does. But when you actually put it and frame it as abolish private insurance, only 13% of Americans support that, which is why when in one of the Democratic debates earlier this year, the candidates were asked to raise their hand if they support abolishing private insurance, and a number of them did. Well, Republicans made attack ads out of that, right? Because this is not a popular position. It's actually even less popular than keeping things as is. In this poll, 14% want to keep things as they are, which is bad, right? And 13% support abolishing private insurance. So this is a very deeply unpopular part of the bill. Now, you might ask yourself, like, why would we abolish private insurance? And the answer is fairness, right? Because and remember, we're only abolishing private insurance for things that are already covered. And the reason you would do that, right, is because if a private employer can offer their private insurance, they might pay the doctor 50% more or double what Medicare-For-All pays. And the doctor's going to let those patients in the door first and give them the best treatment and give them priority. So the basic idea is you shouldn't be able to buy your way to the front of the line, which is why we prohibit duplicative coverage. And we'll talk more about that later, but that is a really important provision to be aware of because that's where a lot of critiques come from.
Yeah, and knowing that distinction between support for Medicare-For-All and support for the actual provisions in this bill is going to be very important, because proponents of Medicare-For-All very often cite that 58% number. They're like, the majority of people support this, including the majority of Republicans. But whenever you actually get down into the nitty-gritty, people very seldom support actual specifics of this bill. So knowing that distinction is going to be very important.
Yeah, it's sort of like saying, do you support equality of all races? Well, yes. I mean, everybody supports equality of all races. Okay, do you support this very specific program for racial reparations? Oh, goodness, no, I'm a Republican. I don't support that at all, right? And that's kind of what Medicare-For-All is. It's like you have tons of people up on the stage in Democratic debates who say, oh, yeah, Medicare-For-All is just the greatest thing in the world. And they would look at this bill and say, oh, no, 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 because the polling would be like really lousy for them, right? And then the last thing I wanted to say about the bill is just provider participation, right? So under the current Medicare system, you as a provider have to opt in, right? You have to become a participating provider, and you have to say, basically, I will accept the rate that the government pays for this medical care, which is somewhat lower than what you would pay in the private sector, right? I will accept it, and I will allow patients to come in, and I will follow all the regulations that are put upon me. And you have a choice. You can either accept Medicare patients or not. Well, under this bill, in theory, you'll still have a choice, but you won't really have a choice, right? Because all private insurance is going away, and almost all medical care is going to be covered. So in theory, a medical practitioner could say, I'm not going to accept Medicare-For-All, and that would mean they are choosing to go out of business, right? Because you would be, the government would have a monopoly, and the government rates and the government regulations and all of those things would become a monopoly on medical care. And this raises concerns about, for example, incentivizing people to go into the medical profession, to stay in the medical profession. Will they be making enough money to work all the long hours and have all the difficulty of it? And they won't really have a choice. Under this one, they have a choice. You can just choose not to accept Medicare patients. And under this new bill, under MFA, in theory you would, but in practice you wouldn't, because it would be the only game in town, right? If that makes sense. So that is my basic summary. Did we cover all the major stuff as far as you know?
I think we covered it.
Okay. So now you know the very broad strokes of how this particular bill works. And so with that, it is now finally time to get to the part that we've all been waiting for, which is the pro arguments and then later on to the con arguments. All right, so let's talk about the pro. I think overall, probably for me, depending on how the round gets framed, I think the pro has the marginally stronger argument here. I think there are a handful of strong, sort of clear arguments on the other side, but the pro has a lot more avenues they can go at. I may change my mind when we start talking about the con on this. I think it's pretty balanced. But a lot of it on the pro just sort of centers on the idea of getting rid of the lack of insurance coverage in this country. And so I'm going to kick it over to Mia, and she's just going to walk you through kind of some of the basic pro arguments.
Yeah. So kind of along that line, one very impactful statement that you can make is simply that ending the lack of coverage as it is a moral imperative. That there's huge impacts of getting people insured, and that any consequences the con can bring up, getting people insured, 30 million people insured, absolutely outweighs that. So there's this excellent summary on the numbers from the Kaiser Family Foundation in December of 2019, and they found that despite the passage of the Affordable Care Act, around 30 million non-elderly Americans are uninsured today. And that's not because of their own choice. 45% of them say it was because insurance just cost too much. 21% said it was due to job loss, because as we know, a lot of insurance in this company is tied to having an employer. 13% said it was due to Medicaid loss, and 3% said it was due to a decision that they simply didn't need insurance. And the rates of being uninsured are not evenly distributed across the population. Kaiser Family Foundation continues that most likely, if you're uninsured, you're a low-income working family and you're a person of color. They're much more often uninsured than whites are. So, we have a very strong argument that it's an absolute moral imperative to get these people insured, specifically because uninsured adults are much more likely to forego medical care that they absolutely need, and they're more likely to be unable to pay their medical bills and to pay for their pharmaceuticals. So no matter what consequences the con can bring up, if we're able to get 30 million people insured and have access to medical care that 45% of them are saying they can't get specifically because it costs too much, we can absolutely argue that's a moral imperative.
I would suggest that you go ahead, and obviously we're going to link to the Kaiser Family Foundation study, but this is probably the single best brief on the problem of uninsured in America, post Affordable Care Act, today. It's from 2019. It's from December 2019, so it's very recent. And it's got a fantastic array of statistics. It gets down to granular levels. For example, one of the big problems with lack of insurance in this country is that the Affordable Care Act leaves it up to the states to expand Medicaid for low-income folks. And so in places like Mississippi and Alabama and South Carolina that are run by conservative politicians, they're opposed to that because they don't like the Affordable Care Act. Yeah. And that's where you happen to see, those are some of the poorest states in the country. There are also states that have a highest concentration of non-white folks, and that means that the problems of coverage, of lack of coverage, are going to be concentrated in those communities. But at any rate, definitely read the Kaiser summary, be able to speak very clearly on it on the Pro, because it's just a wealth and an array of major kind of gut level impacts about lack of coverage that you can use. So.
Yeah, absolutely. And we know that all too well in Mississippi, the effects are absolutely tragic. So there are tons of impacts you can use on that specific contention. Next, we can move into just some specific, general arguments about how single-payer countries have vastly better outcomes than countries like the United States that don't. So first of all, we need to be very clear about citing that according to the Peter G. Peterson, fun name, Peter G. Peterson Foundation, the United States spends the most on healthcare costs out of any nation, the most in general and the most per capita at $10,586 per capita. Now, if we're going to be spending that amount of money, fine, but we're going to need to have something to show for it, right? If we're spending that much, we should have incredible health outcomes. We should have everyone granting access. Of course, we don't. There's a great Commonwealth Fund study that I urge all of you to go read. They do these very, very in-depth analysis of Western countries and their healthcare systems, and they rank 11 different countries. And consistently, since 2004, they've done 6 of those studies, and the United States has been dead last in every single one of them. And that's in measures of equity, access, administrative efficiency, care delivery, and healthcare outcomes. So what are we really defending here? Especially if you can have the con defend the status quo, we're siphoning money into a system that has been largely a failure by nearly every single metric, and we've been last in the developed world. And coincidentally, we're the only country in the developed world that doesn't have a single-payer system.
And one of the things that I would say on this is, these are some statistics that you need to be able to shoot from the hip on. You need to know these cold. For example, $10,586 per capita. Well, you're going to get into discussions about cost, and you're going to be fighting about how we're going to raise taxes and how we're going to fund this. And one of the kind of cut the Gordian knot arguments, to use kind of a mythological allusion there, one of the ways you can make it simple is, I don't know exactly how much the average person is going to have to pay in taxes, but I guarantee you it's not going to be $10,586 per capita, right?
Yeah.
It's going to be less than that, right? We're not going to take a family of 4 that is getting by on, the median family income of whatever 70-something thousand in this country and take $40,000 from them. It's not going to be that. It's going to be less than that.
And there's absolutely evidence that we save trillions over the decade if we implement Medicare-For-All, specifically just because of inefficient administrative costs. So in this dialogue about the cost of Medicare-For-All, you need to be very clear that it's not like we're not paying anything right now. We're paying more than literally the rest of the world is paying. Right. So whenever the con is like, oh, this cost is astronomical, we say absolutely the cost is astronomical today. The problem is today, the costs are astronomical and we don't have any outcomes to show for it. So, for example, we can get into specifics. On access, the U.S., of course, ranks last on measures of financial barriers to care, with 33% of people reporting that they didn't take prescription drugs or visit their doctor or receive recommended medical care specifically because of the cost. Now, this is 4 times that of countries with single-payer systems. Germany reports 7%, the UK reports 7%. So this is a uniquely American problem. It's not one that's unavoidable, especially with a single-payer system. On outcomes, the U.S. is last on healthcare outcomes broadly, specifically infant mortality, life expectancy once people reach age 60, and deaths that were potentially preventable with timely access to effective care.
And I think that that is a really important point to make, which is that, you know, especially if your opponent is the con is not going to try to frame it with another proposal. If they're just going to consent to having a roundabout, we do this or we don't, right? You need to be hammering the idea that this is just a trash fire, right? The United States healthcare system compared to other developed countries is just disastrous. And you need to say it in those terms, like disastrous, you know, a debacle is not an overstatement, right? Infant mortality, life expectancy at age 60, preventable deaths. You know, we're going to obviously post some links on those. I'm not going to talk about every single one of them, but you need to have numbers on those, right? Or at least estimates, right? And you need to be talking in very specific terms about we are paying Ferrari prices for, you know, a GMC Gremlin or an Edsel or it's just some terrible, terrible thing. Like we're paying ridiculous sums for the worst system we could possibly have. Right?
Yeah, and then on efficiency, we're going to talk about this in our next contention as well, but the U.S. is also ranked at the bottom of administrative efficiency. This is a really good statistic, again from the same study. In the U.S., 54% of doctors reported problems trying to get their patients coverage because of insurance restrictions and administrative bureaucracy. And in single-payer countries, that rate is only 6%. So right now, doctors are having a very, very hard time getting their patients the care that they're recommending that they get, specifically because they don't have access to insurance and because they just have such administrative inefficiency.
Later on, and I'm going to talk in just a second, or Mia may, about like exactly how massive the leviathan of healthcare administration is. You are going to be stunned at how many billions of dollars we spend on just administering healthcare, not the care itself. Yeah. And those numbers, frankly, will be shocking to judges. So, at any rate.
And of course, on lives, this is arguably the most impactful thing that you can argue in the round. And generally, the objective of any healthcare system should be to save lives. So there's this great study by The Lancet that found that a single-payer system in the United States, they predict, would save 68,000 lives annually by providing each person coverage. Specifically, remember how we talked about earlier, people who are uninsured don't get the care that they need, they don't get the prescriptions they need, and they don't visit doctors. So whenever you give those people access to the care that they absolutely require, inevitably you're going to see lives saved.
Yeah, I'm going to talk a little bit about, I think, single payer and efficiency because that's something that's kind of near and dear to my heart.
Yep.
So Diane Archer in The Hill has a very good article from February 2020, and one of the things it does is it's not exactly a meta-analysis, but you know we like meta-analyses in debate because they look at a bunch of other studies and kind of tell you the summary. And so what Archer's doing is she's looking at Christopher Kai and colleagues at UC Berkeley reviewed 22 economic analyses of single-payer systems, and every single one of those 22 studies, and these are probably the 22 most reputable studies, found that single-payer saves significantly over the current U.S. system. And this is true regardless of like the ideological position of who was doing the study, right? So even the conservative Mercatus Center found that Medicare-For-All, and that was specifically about Medicare-For-All, the Mercatus study, will save about $2 trillion over 10 years in comparison to the current system. And that's a conservative group. The most conservative estimate is you will save $2 trillion. And what's really astonishing, and this is what I really like the Archer article for, is it talks about how Medicare-For-All is going to save $600 billion of the $812 billion the United States currently spends per year on health care administration alone. And I want you to really just let that sink in, and I want you to let the judge let that sink in. It is obscene that we spend $812 billion, $812,000 million a year on health care administration. That is more than the $738 billion we spend on defense. It is 10 times the federal education budget of $68 billion. And this is not what we spend on health care itself, but this is what we spend on billing disputes, on insurance companies trying to deny coverage, fighting over it, going to court. This is what we pay hospital administrators whose job is to make the hospital, they may be doctors, but they're not practicing doctors. Their job is to make the hospital profitable, not to take care of patients. So we are spending more on paperwork and administration, significantly more than we spend on the entire United States military, which is larger than the next 10 militaries in the world combined. And to say that we're going to, and there is an argument that you can make that this will significantly, Archer says we're going to get rid of about $600 billion, and that's common sense. We're not going to have coverage disputes anymore. We're not going to have fights about what's covered, right? We will have an appeals board, I'm sure, but you're not going to have hospital administrators who have to go out and try to negotiate with insurance companies. There's going to be one that you negotiate with. Now, are there downsides to this? Yes, we'll talk about it on the con, definitely. But $600 billion a year saved in administrative costs, I just think is a major, major point you should include. So anyway, I'm sorry, I just had to digress a bit.
Yeah, absolutely. Let's not act like we're not paying right now. We're paying absolutely ridiculous amounts of money on our current healthcare system. So if we pass Medicare-For-All Act of 2019, not only do we get rid of these administrative costs, we also provide access, and we also provide care to people. We provide quality care to people. Next, we can move on to another argument that's actually very timely and specific to COVID-19, and that is that COVID-19 expresses why we must end dependence on employers for health coverage. This is something that was talked about a lot in the election cycle, and you should definitely exploit it, especially in the context of COVID-19. This is the People's Policy Project of Matt Bruenig. He says, quote, "The truth is that people who love their employer-based insurance do not get to hold on to it in our current system. Instead, they lose that insurance constantly, all the time, over and over. It is a complete nightmare." So basically, we can argue that the Medicare-For-All Act of 2019 provides this inherent security to people because unlike our current system where people may change jobs, employers may choose a different insurance plan, people may be laid off from their job like they were during COVID-19. People are going to have security within the healthcare system. Their lives aren't going to hang in the balance if their job changes every once in a while. Of course, as I said, this is particularly important during COVID-19. That same article showed that more than 1/4 of those losing coverage because they were laid off during COVID-19 would remain uninsured right now. And this is even worse in states like our own, where we didn't expand Medicaid coverage. It predicted that 40% of people who became unemployed will remain unemployed because obviously they have no other option to turn to. We didn't expand Medicaid in states like Mississippi, for example. Next, we'll move into gender discrimination, and that Medicare-For-All Act of 2019 would eliminate discrimination against trans people in medical care. Now, this is also incredibly timely. The Human Rights Watch reported in June of 2020 that right now the Trump administration is pressing for a rule interpreting the Affordable Care Act that would remove anti-discrimination protections for transgender and other gender non-conforming people. Now, this is a major problem. You may not realize up front, but right now, according to the National Transgender Discrimination Survey, nearly 1 in 5 trans people report that they've been denied health care simply because of their identity as a trans person. Now, we're not talking about care that is correlated to their identity as a trans person. Like
not just like gender affirmation surgery or something, right?
Yeah, not anything like that. We're talking about just medical care, period, that they were denied because they were a trans person. So the Medicare-For-All Act of 2019 solved this problem by explicitly defining in the bill tangibly that you can't discriminate in health care, in medical care, based on gender identity, sexual orientation, and biological sex and pregnancy. It does this outright in the statute itself by not allowing future administrations to take that right away, or future administrations, or even the current administration, to remove protections for transgender people in medical care.
Another one that is kind of nifty, that is kind of financial in nature, but not exactly, is that the bill eliminates financial conflicts of interest. So Section 301(b)(2) of the Medicare-For-All Act of 2019 creates what's called the provider duty of ethics. And it says that every provider and institution that participates in MFA, which by the way will be pretty much everybody, has a duty to advocate for and act in the exclusive interest of each individual under the care of such provider according to applicable legal standards of care, such that no financial interest or relationship impairs any healthcare provider's ability to furnish necessary and appropriate care. What does that mean? It basically says you're going to have a legal requirement to put patient care above profit. You might say, well, surely that's already the law, Brett. And the answer is, well, in most professions it is. As a lawyer, I have what's called a fiduciary obligation to my client. I have an obligation to do what's right for them before my own pecuniary interest. Accountants have it, and physicians themselves have it. But you know who doesn't have it? Insurance company executives. And you know who else doesn't have it? Hospital administrators. Those are, remember we say we spend $812 billion a year. Hospital administrators have no direct obligation to give you the best possible care. Their job is to be efficient, right? And more frankly, efficient is another way of saying ensure that the hospital's making a profit. And so what this bill is going to do is it's going to say that medical care ought to be solely in the interest of the patient, right? It's going to create a legal and enforceable duty to do that. And so what you will not be able to do under this provision is you will not be able to have something that says, well, the hospital administrator gets a bonus if he keeps the coverage cost for cancer patients under X dollars per person. And that's kind of an extreme example. But you're not going to get rewarded and get bonuses and get stock shares and things like that if you are cutting costs and cutting doctors. And by the way, this is also relevant to COVID-19 because you go out and read articles right now about how there are hospital administrators who are earning their bonuses by cutting staff during COVID-19, sending frontline doctors and surgeons and things like that home, and they earn their bonuses by cutting costs. Now, I'm not trying to rag on all hospital administrators, but they exist to ensure profit, and this bill is going to say that everybody involved in the process can't put profit ahead of people, and that's something I think that a lot of judges would find reassuring. So.
Yeah, I think this act is kind of one that cements exactly what a healthcare system is meant to do, right? It says if healthcare systems are not serving us, if they're not served to keep people from getting sick or at the very least to alleviate sickness, then who in the world is it serving? So I love that Medicare-For-All Act of 2019 takes away that interest, and it says, no, the purpose of the healthcare system is to actually serve patients, not executives and administrators.
Now, I don't want to be naive. We'll talk later on the con about how, to stay in business, any business has to make some profit, and we have to be fair about that, and we will talk about it. But the idea of it should not primarily be about profit is one that's going to resonate with a lot of people. Yeah. So. I will say, we talked earlier about how there's some specific little pockets and corners of the bill that have interesting things, and one of them is about prescription drug prices. And this is going to be one that could actually cut either way, so we're going to actually come back to this on the con too, right? But on the pro, Kaiser Health News in 2019 points out that the MFAA bill would take a swipe at high prices for prescription drugs by empowering the government to negotiate prices directly with manufacturers and take away and reissue drug patents. Now, this idea of negotiating directly is pretty common. The Trump administration claims that it's even going to currently do that, and it's something pretty much everybody advocates for in terms of lowering prescription prices. But this other idea of taking away and reissuing drug patents, right? And this is in, I can't remember exactly, it's in section 616 of the bill. So again, looking at specific sections, you will have something called compulsory licensing, right? And what will happen is if the government tries to negotiate with you for a price on your drug, let's say you're Pfizer or whatever, right? And they negotiate with you for some, really important cancer drug, and they can't get to a price that they think is acceptable, they can take your patent, which is your ownership over the drug, your exclusive right to sell the drug, right? And they can take it and give it to another company, and take your formula and give it to another company and let them manufacture it, right? This is pretty dadgum extraordinary, right? I mean, this is going to give them a lot of power to basically say, to dramatically lower drug prices. Now, on the con side, you're going to say this is totally unfair. I mean, this is seizing property, but basically, we're going to use government power very aggressively, right, to drive down drug costs. And at the end of the day, there's really not going to be much that a company can do if we find the price is excessive. So if you want to talk about lowering drug prices, there's a really, really uniquely strong, like this is different from what other bills do. Right? Other bills don't do this. This is going to be the most powerful effort to rein in drug prices of any of the options that you see out there, and that's important, right? So.
Yeah, if you can include some statistics, some impacts about how absolutely lethal it is that prescription drugs cost as much as they do, that would be great. Really hammer those home.
And as it turns out, we actually can help you with that because we did a video on price caps, and so we're going to link to that video and do some timestamps about where exactly we talk about like how bad pharmaceutical prices are currently in the status quo. That was a couple of years ago, but it's still pretty current.
Question. Where did you say that source came from?
It's Precision Health Economics.
And what is that?
It's a think tank.
And where is that think tank from?
This think tank is,
I mean, are you trying to say basically that this is a think tank that works with the pharmaceutical industry? Right.
So you can go watch that and get a sense of like if you want to run prescription drugs as part of your case, it's got a lot of good impacts about like how you've got $1,000 treatments for a disease that can kill you and you have no other options. And it's, there's a lot of stuff in there. We won't cover it now, but you can watch that video and learn a lot about what the specific impacts are of doing nothing, right? A couple of kind of defensive points before we wrap up on the pro is like, I think these are not really so much like offense, but like things you need to be prepared for, is just kind of normalizing the idea of what we're doing with Medicare for All. Because what the con's going to definitely try to do is make this seem like it's this massive, extreme, sort of socialist, Bolshevik, crazy expansion of the government, right? And that's what's done in the real world. And even nuanced teams are going to say this is an extreme step, right? And I think you need to be ready to kind of hit back preemptively or be prepared on a couple of points with respect to that. So, the first one would be this idea of banning private coverage. We talked about how that is really deeply unpopular, and we're going to talk about that in a second on why it's a problematic issue on the con. But one thing you should know is there's an article from Spross in 2019 that points out we're actually not banning all private coverage. We're banning duplicative private coverage. In other words, things that duplicate what Medicare for All does. And the reason we're doing it is we don't want private insurers to be able to pay more to get their people to the front of the line, right? And this is something that's not uncommon at all. This is done in a number of countries, and we can cite examples. We'll probably try to pop one up on the screen, but a number of countries do this. So you can still have supplemental private coverage for experimental treatments, treatments that are not proven yet, I guess cosmetic surgery, things that aren't covered by Medicare for All. Will it be smaller? Yes, it'll be dramatically smaller, but that's a good thing because, again, $812 billion in administrative costs, right? And then lastly, this idea of the government handling nearly all of healthcare, like government being a near monopoly on healthcare, is like, is this scary thing, right? And some judges, certain parts of the country with certain sort of backgrounds may think, that's really scary. But you need to be able to normalize that too, right? And so a few talking points on that. Number one, it's what nearly all developed countries already do, right? So we're the outlier, right? We're the weirdo. And the way you say it is like, the market works great. Like the free market works great for things that are optional, right? For things that you're prepared to say people shouldn't have. So for a 70-inch 4K television, the market's great, right? We have 1 million different supply providers create it, and they'll compete with each other, and we'll get better TVs. Luxury cars, fine. Luxury housing, that's all great. But when we decide that there is something that a person should never be without, and I think we have decided that medical care is something no one should be without, the market is not great, because the whole point of the market is to have a market. The parties have to be able to walk away and say no. It's not a market if you can't walk away and say, okay, I won't sell you this, right? And
people are inherently excluded from a market.
Right. The whole point of a market is, you set prices based on supply and demand, and you have to be able to walk away from the deal.
Mm-hmm.
I'm not a big Donald Trump fan, but one of the points he got right is there's no such thing as a negotiation. If you're negotiating with somebody and you are not free to walk away from the table, you're not really negotiating. You're just either bluffing or begging, right? So that's kind of how markets work, right? The second thing is we're already between half and 2/3 of the way there to having the government pay for it, depending on who you look at. Archer argues that we have about 2/3 of our total federal spending on healthcare is done through a mix of multiple state and federal programs. There are other sources you can look to, like for example, the Department of Health and Human Services itself right now, like the Trump Department of Human Services says that we're paying 45% of healthcare costs. So we're already between half and 2/3 of the way to doing this anyway. We're just doing it through a messy, complicated, expensive mishmash of programs combined with some private sector expenditures. So the idea that we're going to have the entire medical sector funded through a single payer by the government, we're getting there closer every single year. Like we're going to rise from 45% to 47% if we do nothing by 2027. So it's not unusual at all, right? That's what I got on the pro. Anything else?
That's everything for me.
Fantastic. Let's move on and talk about the con. All right, so rounding things out, let's talk a little bit about the con side. When I first started working on this, I thought that just because of sort of the general sentiment that healthcare in the United States is, got its problems, that the con was really at a disadvantage. But the more research I've done, I think that we've done, I feel stronger that some of these positions are actually pretty viable. I think it's pretty well balanced. I think there's two basic ways you can come at the con. One is just sort of a frontal assault on the bill itself, and just there are a number of different ways you can come at it. We're not going to have time to cover all of them, right? There are major issues like cost and funding that you're going to have to talk about, and then there are other more esoteric things like timing and pharmaceuticals, and you can nitpick a million different things, right? And you may want to work some of those in. But there are different ways to come at just sort of the bill is bad, we should not pass it, right? The other alternative is, as we said earlier, if you believe you can get away with it, to offer an alternative, to look to a different legislative proposal. I would probably limit it to actual legislative proposals because, again, that's kind of symmetrical. Now, you may feel like you can't do that. Maybe the folks in your region would just, no matter how logical it is that a plan and a counterplan are the same thing, the stuff we talked about earlier, they may not buy it. You may say, I'm not going to do that. I totally understand if that's the case. But we want to talk about that at the end. We're not going to go through every single one and do massive comparisons, but we just want to give you some ideas, and we'll try to drop some links to analyses of comparator bills. So if you want to build a case around that, you can really try to find one you like and sort of craft an alternative like that. But the first thing you have to say and to attack the bill on its face is there is no plan to pay for it, right? This is the single biggest attack you're going to see on Medicare for All. And that's a big, big problem, right? You had a good analogy earlier about like student, what were you saying?
Yeah, basically, I don't want to understate how big of a deal it is that they don't have funding in this bill. Even in student Congress, if you've ever competed in that, these are one-page bills. Even in student Congress, you're required to have a funding source for that bill. And if you don't have one, you're very likely not even going to get on the docket for that bill, for that congressional debate round. Even like middle school youth legislature, you have to have a funding source on that bill. And if you don't have one, it's going to get thrown out. So the fact that this one doesn't clearly articulate where it's going to be getting that funding is very problematic.
And yes, exactly. I mean, and it goes even deeper than just it isn't funded. It goes to what happens when you pass a bill without funding it. And we'll get to that in a second, but there are impacts on that, right? Because it doesn't just like not happen, bad stuff happens, right? So let's talk about where funding comes from. So to start with, we know that Section 701B2 of the bill, again, getting our sections precise, right, clearly says we're going to take funding from Medicare, Medicaid, and all these other programs that Mia mentioned earlier, and we're going to dump them into what's called a Universal Medicare Trust Fund. Okay, so right off the bat, though, we know that all those programs cover somewhere between 75, maybe 85 million people. So Medicare and Medicaid are the big ones. They cover 75 million people, and there are a few more on these other programs. So, let's say that we get, roughly 75 million people. The cost of that is going to be dumped into this new system. So those people are taken care of because we're just taking money they were getting anyway, right? Well, that's still going to leave about 250 million people who were not covered, right, by federal, federal insurance programs, or at least somewhere between 200 and 250. So hundreds of millions of people. So where are we going to get all the additional money, right, that we're going to need to pay for health insurance for these hundreds of millions of people? And the short answer is there's a massive debate about, like, first of all, how much is it going to cost, right? How much is it going to cost? And there is no set answer, but there's a wonderful interactive page that the New York Times has that we will link to that has like the 6 biggest estimates of what the cost will be, right? And they are all in the trillions of dollars per year. Like, and to put that in context, our entire federal budget for this past year, 2020, was $4.8 trillion, right? So, it's a huge, huge amount of money, right? But it has a very good interactive page that summarizes how much it's going to cost to insure all these new people. And the short answer is, if you look at the different estimates there, you're going to see that the bottom line is the total cost per year is going to range somewhere between $2.7 trillion to $3.8 trillion per year. That's the consensus of the experts and the studies that they cite, right? Okay, so remember we said earlier we're going to be getting rid of all this, and that's 2.7 to 3.8 in comparison to an entire budget of 4.8 trillion, which is, we're talking a lot of money here, folks. So current federal spending on healthcare, as we said earlier, is roughly about $1.5 billion per year. So, okay, let's subtract that 1.5 from the money we'll need. So we said we needed 2.7 to 3.8, so we'll subtract the 1.5 we already have, we'll take that out, and that means that roughly ballpark, we're probably going to need somewhere between about 1.2 trillion to about 2.3 trillion new dollars, right? And this requires doing some math, but we're basically just sort of applying current expenditures and subtracting them from estimates of cost, but I think it's a fair estimate. 1.2 to $2.3 trillion is 2 to 4 times the entire military budget for the United States. It is 20 to 40 times the entire education budget for the federal government, and we're just going to have to make this new revenue appear somehow. Well, how are we going to do it? How does the bill say that we're going to raise this money? And the answer is it really doesn't, right? Now, it does provide for some new tax revenue, kind of, and let me explain what I mean when I say kind of. There is the only tax provision in the MFAA itself is Section 701B1. And what it says is that any new tax revenues that are generated by a couple of other sections, 801 and 902, will go toward funding the MFA. So 701 says any new tax revenues we get from 801 or 902 in the bill will go to MFA. So, okay, great. So what did those two sections do? What do 801 and 902 do? What new taxes do they implement? They don't. What they do is they get rid of employer health coverage, and they get rid of coverage under the exchanges, the state exchanges under the Affordable Care Act. Now the theory here, and I may be wrong on this, but I did my research and I think as I understand it, the theory here is that if you get rid of these benefits that employers are providing, which by the way are not taxable, you don't get taxed on the amount your employer provides for your health care, right? Your employer will give you more cash in your salary, right? In other words, instead of spending $15,000 on your health plan, they'll give you some amount of money, maybe $15,000 as an increase in salary, maybe not that full amount, but you'll get more money in salary, and that salary in turn is taxable, right? So everybody will get a raise in terms of cash, and we will start taxing that raise, right? You know, pretty significantly, and then that money, right, that money will be used to fund the plan. Okay, so fair enough. How much money is it going to be? The answer is we have no idea. We don't know how much employers are going to raise people's salaries. They're not going to give you the full amount, right?
We don't know if they will at all.
Well, we don't know if they will at all, right? We have no idea. Now, the market economics suggests that some probably will sometimes. We have no idea whether they will or to what extent, but let's assume they do. Okay, so Elizabeth Warren, in her defense of Medicare for All, says that she believes, and this is her theory, she says that employers would be spending $9 trillion over the next decade on health insurance. So let's assume they take every dime of that, every single dime of that, and they give that entire $9 trillion that Elizabeth Warren says they're going to spend, and they give it back to their employees, okay? And let's say we tax it, right? So we're going to tax it at, let's say that the average rate for the most taxpayers between the $40,000 to $85,000 a year is 22%, okay? So we're going to tax $9 trillion at 22%, and that's going to give us $1.98 trillion, not per year, but per decade, right? So we're going to get about $200 million per year out of that tax. Great, $200 million. But remember what we said earlier, which is that we're going to need at minimum somewhere between $1.2 trillion and $2.3 trillion to pay for this. Where is that money coming from? We don't know, right? Now, Bernie Sanders has these great sheets where he lists all these alternatives and all of these, different ways we could do it, tax the wealthy and, payroll taxes on employers and things like that. But here's the thing, you as the judge in this round can't fiat that. You don't have the ability to vote for that. When you vote, that doesn't happen. That's not part of this bill. You cannot vote for it, and you can't guarantee that it'll happen. And given the adversity that most Americans and conservatives and Republicans in particular have to tax increases, your opponent's going to have to show not only that those could work, but that they actually will be passed into law. And I don't know of any very strong argument that we're going to pass new payroll taxes on people. Everybody thinks we ought to tax the rich, but it hasn't happened yet. So your opponent to have a viable way of funding this is going to have to not only say these could work, but that they empirically prove as a fact that they will happen, because the judge can't make them happen, right? Okay, so that's bad, right? We're in a situation where we're not paying for a bill, right? And that in and of itself, as Mia says, should be a major cause for alarm. It would be in any round of student Congress, right? But there's even more of a problem, right? Because basically, if there's no plan to pay for it, then you're assuming huge risks of what's going to happen down the road when we have what's called an unfunded mandate in the federal government, right? The truth is, if you listen to real-world advocates of robust Medicare for All, their real plan, honestly, is to what I call throw your hat over the fence. Basically, pass the bill, right, and then we'll figure out how to pay for it. Like if you throw your hat over the fence, you're going to have to find a way to get over the fence because you got to get your hat back, right? I'm sorry, I'm old, but it's an old saying, right? So the idea is basically that we'll figure it out later. But there's at least two, there's many, but I can think of at least two major impacts that are big problems with this. The first is the budget deficit, right? So in 2019, our budget deficit, and that's just the amount we fall short in spending. This is the amount of money we have to borrow because we don't bring in enough revenue to pay for our federal spending. So every year you have a deficit, right? So our deficit was $984 billion, or almost $1 trillion, right? In 2020, due to COVID spending and economic harms, it's going to be, hold on, $3.7 trillion because of all the stimulus money we sent out, lower revenues because businesses are closing and things like that. Okay, it's $3.7 trillion that we have to borrow out of a $4.8 trillion budget, right? On top of that, the national debt is now about $26 trillion, which is larger than the entire size of the annual productivity of the economy. So we would basically have to just work as like servants of the government to, not the government, to our creditors to pay off the national debt like in 1 year, right? So, and we've actually done an entire video, speaking of our prior videos, we've done an entire video on why the national debt is unsustainable. Well, it's both sides, obviously, but it's about limiting the national debt. And I'm going to put a link to that. I'm going to put timestamps to like where we talk about why the debt is a trap and it's unsustainable. But the basic idea is the more debt we get, the more interest we have to pay on it, and the interest payments on the debt like choke off our ability to pay for things in the long run. So it's basically, it's incompatible, right? You can't on the one hand say, we're going to add huge expenditures that we need more money for, right? How are we going to do it? Well, we're going to take on debt. But if we take on debt, aren't we going to have to make interest payments on the debt? Yes. So in 20 years, aren't we going to be paying so much interest that we can't afford this new great thing we bought? And the answer is yes, right? I mean, we cannot have both a massive new expenditure and massive new debts, right? So watch the section of the video that I send you to on that if you want to run a debt impact. Because it's not just like, the argument here isn't just like a traditional, oh, debt is bad and it's irresponsible. That is in the video. It is irresponsible. It is bad for future generations. It's me dumping stuff on you and you dumping stuff one day on your kids, right? But beyond that, it's just, this can't continue to work. We can't take on a new $2 trillion a year expenditure and massive new debt to pay for. Eventually, the latter will choke off the former and render it impossible. And that's basically what the argument is, right?
Yeah. And a lot of the response on that is usually something along the lines of, well, just because it costs a lot doesn't mean we shouldn't do it. We should save lives and prioritize lives over money. But the con needs to be very prepared to say that lives and the economy are not at all like mutually exclusive, right? Like if our economy collapses like it did in Greece whenever they accumulated a giant national deficit, people's lives were absolutely torn apart. People's lives collapsed just like the economy did. So let's not act like these things are completely separated from one another. They're absolutely inextricably linked.
And the other thing is, if you actually persuade the judge that the interest on the debt is going to choke off our ability to pay, then it's not really a choice between money and lives. It's this thing won't work, right?
Yeah.
The argument will be, 15, 20 years down the road, this system that we've set up will not work because we will owe our creditors so much money that we will no longer be able to pay for this thing. And if you think that's hypothetical, I urge you again to go watch the video we did, because there are very realistic scenarios in the next 40 years or so where we are, paying half of our federal income to creditors because we borrowed so much, right? And it takes a little bit to set up that argument, but if you set it up correctly, it's like we're not trading anything off, Judge. The system doesn't work, and presumably, if we're setting up something as massive as this, we don't intend it to be like a one-off. We intend it to be like the National Health Service and to last for decades. And the point is, it'll collapse. We won't be able to pay for it, right?
Yeah.
So that's the argument.
Future administrations will have absolutely no choice but to say, oh, well, I guess we have to make cuts to Medicare-For-All. Oops.
Well,
Yeah.
speaking of which, the other part is that in the nearer term, passing a bill without a dedicated statutory funding source is immensely politically risky, right? It trusts the future of this system, and because this system encompasses all healthcare, to the goodwill and the wisdom of future politicians. And I don't know if you've been paying attention lately, but there's not a whole lot of that, right? So, and here's the example. Like, look, back in Obama's first term, when we passed the Affordable Care Act, everybody assumed that Republicans hate this thing, but like in a few years they'll be okay with it and they'll be fine with it. But they haven't been. Republicans are still fighting tooth and nail to abolish and challenge and waylay and harm and reduce everything about the Affordable Care Act that they can. Every chance they get to go to court, every chance they get to defund it, they still do it, right? And so, but at least with the Affordable Care Act, it didn't require solely federal funding, right? States could do it. So if states want to expand their Medicaid exchange, they get, like Democratic states can do that, right? On this one, it's going to be solely based on federal appropriations, which means that this trust fund that we're going to be setting up, and this shortfall that we have of $1 to $2 trillion, that's going to have to come from future governments putting money into this thing. And statistically speaking, half the time, those future governments are going to be Republican, right? And if they don't like this system, then all they have to do is starve it. And if you don't think that they will starve it, again, I would urge you to look at the last 10 years of what Republicans have done to try to retroactively kill the Affordable Care Act any way they can. If you want to have a system like this, what this means, now you might say, Brett, what are you saying? Are you saying, well, we should just never try because we think Republicans might try to tear this down? No, I'm saying if you're going to have a bill, it needs to have a dedicated, statutorily designated funding source in the bill itself, because what you're doing is you're saying, boy, I sure hope 5 years from now that a Republican president in Congress will pass some massive taxes to pay for this thing. Well, I got news for you, folks. They won't. They won't. And if you're just hoping and wishing on a star, you might have a Democratic Congress do it for a couple of years, but then when power changes hands, right, they're going to take it away. And it's worse than the Affordable Care Act, because at least for the Affordable Care Act, you still had employers providing some of the insurance. If it's all in the hands of the government and the Republican Party or whoever, conservatives or fiscal conservatives, can starve it, they will. So it is massively risky. It is massively irresponsible to say we're going to put all our eggs in one basket of national health care and cross our fingers and hope that a political party that is diametrically opposed to federal health care is going to come up with a way and approve and assent to a way of funding it. That is insane in terms of riskiness, and you just can't do that, Judge, I think is the basic message. So.
Yeah, absolutely. So this kind of goes along the same line that Medicare-For-All Act of 2019 leaves so much open to interpretation by federal authorities that, like Brett said, it almost makes the Secretary of Health and Human Services God in this world. So generally, Medicare for All provides comprehensive benefits, but in this bill, they don't specifically outline everything that's covered. All they say is that health care will be appropriated as is medically necessary and appropriate. So, of course, that encompasses a lot of things that are fairly obvious, like insulin for diabetics or a cast for a broken leg. But a lot of things are not that obvious. And that's where the Secretary of Health and Human Services comes in. It basically says the Secretary has the power to decide what is medically necessary and appropriate. So what happens for things that are controversial or tricky to decide if they're actually medically necessary and appropriate? Like we mentioned earlier, is gender affirmation surgery medically necessary and appropriate? There's certainly evidence to indicate that it is, but there's also people who disagree with that. Absolutely. So those things are a little bit less cut and dry. Here's the problem here, okay? The current Secretary of Health and Human Services, a lot of people believe them to be incredibly swayed by political influence. That's because the current Secretary of Health and Human Services was a former pharma executive and pharma lobbyist. So basically what you're doing whenever you pass this bill is you put all of the authority to decide what is covered for people's health care in the hands of someone who is very likely to be swayed by political influence. Not only do you do that, you make it incredibly volatile because the Secretary of Health and Human Services changes every 4 years with administrations. So is what is covered changing every 4 years as well? That's not at all secure as what the pro would like to tell you. They'd like to tell you a Medicare for All system is one that is inherently secure. Well, if what is changing, if coverage is changing every single 4 years, that's absolutely more volatile than it would be right now.
And I think one other way to frame this is people say, like every other country in the world does this, but the truth is other countries have a fundamentally different culture when it comes to their, like the National Health Service in Britain has bipartisan support. Everybody accepts that it's the law. Tories accept that it's the law. Yeah. Liberal Democrats, Greens, everybody accepts that it's the law, and they all agree to fund it. In this country, we have one political party that is half the country that just doesn't believe this is the way things ought to work. And if you give a political appointee who 50% of the time is going to come, I'm not trying to knock Republicans. I know we've got folks here who are, I'm just saying they don't believe in this. And if you're going to put this system in place and give the controls to one man or woman who is going to be, from that party and just doesn't, it's kind of like putting Betsy DeVos in charge of education, public education. She doesn't believe in public education, right? And she's, but it's even worse because it's not just education, it's people's lives, right?
Yeah. Honestly, one thing I would do is legitimately ask your opponent in Crossfire, do you know who the current Secretary of Health and Human Services is? And if they can't tell you, then they have absolutely no place to be advocating that person be in the authority to decide who gets what care and who doesn't.
One really interesting trap would be, would you trust a big pharma executive to decide unilaterally what kind of health care you should get?
Yeah, that's the follow-up.
And they'd say no, and you'd be like, well, you're going to not like this bill. Tell you what. So anyway, it's a fun trap you could do if you wanted to be a little bit, of course now we've said it on the channel, so everybody will be ready for it. But anyway, sorry.
Yeah, absolutely. Basically the argument is those things need to be tangibly clarified in the bill, not changing every 4 years with administrations. Next, we can also talk about how having absolutely no cost sharing allowed is financially just impossible. There is a reason why the rest of the developed world doesn't do this, and that's according to Drew Altman of the Kaiser Family Foundation in 2019. No other developed nation has zero out-of-pocket costs, even those that Medicare-For-All advocates cite as goals of what we should be reaching, even those that treat healthcare as a basic human right. They allow for cost sharing. They allow people to purchase healthcare outside the plan, and both of those things together. And there's a reason why they do that, and that's because it's absolutely financially impossible for you to have absolutely no cost sharing whatsoever. Even in the UK, which is very famous for saying that care is free at the point of use, people are still paying $632 per person on average for out-of-pocket costs. That's much less than the US, but it's still more than half. So we can see that the rest of the developed world, they have absolutely no cost sharing. So we need to really analyze, is it possible for us to do this? Why isn't anyone else doing this?
There are alternative proposals that do allow for basic copays, right?
Yeah.
And so one of the things you can say is this could be just one of those things where you say like, yeah, okay, we'll stipulate, we agree that a Medicare for All system is good, but all the other countries have some amount of cost you have to pay at the point of use, if for no other reason than to dissuade you from just going to the doctor when you prick your finger, right? Those kinds of things. And I wouldn't be glib about it. You need to be sensitive. And I should have said this earlier. You need to be sensitive generally to this because you could be debating people whose parents have lost their insurance. You really could right now. And you need to be very sensitive to the realities of that. But at the same time, you say, you know, we want to have something to dissuade people from going and using scarce medical resources, right, for every tiny little headache that they have, right? And that's what a copay does, right? And every other country in the world, the ones have been doing it for 50 years, all think that's right. So this is not a reason to do nothing, but it is a reason to prefer X alternative bill that has a copay because there are plenty of them that do,
Yeah,
right?
absolutely.
So coming back to a specific point we had earlier, to kind of get into some more nuanced points about the con, we talked earlier about prescription drug prices, and we said that under Section 616 of the bill, we're going to be giving the federal government this unique power to take away drug patents and like give them to somebody else. Now, you would, if you were the recipient of the patent, you still would have to pay like some royalties to the company that invented it, but it would just be, you know, whatever the government decides is a reasonable amount, which presumably if they're trying to lowball you on the price will be very, very low. And so, you know, Wes Smith in the National Review on March 11, 2019 basically points out, you know, that how willing would pharmaceutical executives be to green light billions in investment required to develop new medicines, knowing that the government could simply seize their patent and license another company to manufacture the drugs they refuse to sell to the government because of their price demands. The government, number one, is the only game in town, right? Because they're running Medicare for All, they're the only major source you can sell to, right? But you don't even have the ability to say, fine, we'll shut it down, we won't sell to anybody. You don't even have that as a negotiating tactic because they can take it away from you and let somebody else sell it to them. It's like if you're trying, you know, you build a house and you're trying to sell it to a buyer, not only do they not have to buy it, fine, but they can seize it from you, give it to somebody else and let them sell it to them for a lower price. I mean, it's a little bit absurd. The other sort of relatively small concern, not a small concern, but more sort of limited concern is the idea of encouraging undocumented immigration and potentially overburdening the system, right? Remember what we said earlier, which is that, you know, under Medicare for All, under this particular act, we're not going to limit coverage to just citizens or even lawful residents, but undocumented residents as well. The only exception is if they came here for medical tourism solely for the reason of medical care, they wouldn't be covered, but anybody else, and that's going to be the vast majority of folks who come to this country, documented or undocumented, lawful or unlawful. You need to be very sensitive with this, right? We're not in any way attacking people who come to this country, whether they're documented or not. You know, as I said earlier, if I had a sick child or a sick wife and the way I could get affordable care for them was to come here, I wouldn't hesitate to sneak across a border. And you're not condemning anyone who does. What you're saying is that by having that draw, that attraction of, you know, subsidized medical care, you're going to attract a lot of folks. And this is why other systems, other countries around the world, you know, in the NHS in Britain and in other systems, there are restrictions on who can use it. And by completely opening up the eligibility for who can use it, you're going to be overburdening the system with too much cost, because why wouldn't people come to the United States to try to get medical care? It's a huge, huge incentive. And so again, Wes Smith of the National Review basically says that, you know, the only exception is going to be for people coming here solely for medical tourism. That's a very narrow exception. So if a term he uses is illegal alien travel, travel here to work to escape violence or to be with family, the exclusion clause would not apply. And so that is, in terms of creating what we call a moral hazard or incentives, that would be an incentive to overburden the system. So those are the last two sort of limited points I have. I think the final thing we need to talk about is if you choose to go down the road of offering an alternative, what are some alternatives you can use and how might they work, right?
Yeah, so there are a million different alternatives that you can propose. So obviously we're not going to be talking about all of them in too much detail,
Right.
but we can give you just some examples that you can base some of your research on. Just some of the more popular ones, like ones that create a public option, for example, the Keeping Health Insurance Affordable Act of 2019 and the Choose Medicare Act of 2019. Both of those bills create a public system that directly competes with the private one. And this actually most closely emulates the systems in most other countries. For example, Japan, who is ranked #1 in healthcare coverage among 17 developed countries on a number of different metrics. They have 70% of their population enrolled in some private insurance, and they also have a public option that competes. So the way that they got to that #1 standing was they had this competition between the two, and they incentivized private companies to make their care more affordable, to make their care more quality. Another reason why you can feel comfortable proposing a public option plan is because it's incredibly popular among the populace. Unlike the specifics of Medicare for All, a Marist poll found that 90% of Democrats, 70% of independents, and 46% of Republicans are in support of a public option. Now contrast that with the numbers for completely eliminating private insurance. That's 14% Republicans, 39% independents, and 64% of Democrats. Now that approval rating is incredibly important whenever you talk about how Brett was talking about how whenever you completely leave the appropriation of these bills up to an executive, their approval rating is going to be incredibly important because you're not going to starve a system that has overwhelming support. You are going to starve a system that only 14% of your constituency supports.
Yeah, the basic idea is, sometimes people say in debate rounds like about policy that polls don't matter because you as the judge have the power to just make the policy happen. And that's true. You do have the fiat power, right? That's the term, to make Medicare for All be enacted. That's the term in the resolution. But what you don't have as the judge is any magical power to make sure it's taken care of in the years and decades to come, right? So one reason why popularity could be an impact in the round, right, is that a deeply unpopular system, well, you can absolutely predict that something that has 13% support, like getting rid of all private insurance, Republicans are immediately going to turn around and raid that as hard as they can. Whereas if you have something with 70% support, like roughly in line with what you see for the National Health Service in Britain, maybe not quite, but close, it's going to be a lot harder for politicians in the future to go and try to dismantle it and attack it. So actually, even though, yes, you, judge, can wave your magic wand and make it start, you don't have the ability to keep it healthy, and if you want to keep it healthy, no pun intended, you need to choose an option that has more public support because there'll be pressure to not attack it, right?
Yeah. You could even make it as simple as advocating for single-payer plans that give you more time to implement those plans. So for example, Bernie's 2017 Medicare for All plan. It's very, very similar in terms of what it covers, but it gives us twice as much time to implement it. And it could even be that simple. You could say, Judge, we completely agree that single-payer is the goal. We completely agree that the status quo is insufficient, but we need more than 2 years to implement it. We can't just absolutely cause this whirlwind and this hurricane among families by implementing it overnight. We have to do it gradually over time.
And make it as simple as that. This is not a debate about whether we should have universal coverage. We completely agree. You can disregard the entire, you can disregard the entirety of their case, basically. This is a debate about do we do it in 2 years catastrophically or 4 years with more of a lead-in time. If you believe you're able to do alternative plans, it can be something as specific as that completely cuts the legs out from under, especially if the pro is speaking first, it completely cuts the legs out from underneath their case, right, if you believe that's legitimate. Again, we know it's controversial, but again, it's such a weird resolution. So anyway, those are, I think as quick a survey as we can do of all the different options. It's such a huge topic. I know this has been a long video. Thank you for sticking with us. So without further ado, I guess we will do some final thoughts. So final thoughts, really quickly for me, I would say you're going to be doing virtual tournaments on this topic, I think, for everywhere in the country. I don't think there's anywhere where you're going to be doing in person. And my biggest piece of advice would be, get prepared for it. Get used to, if you haven't done one yet, get used to how the Zoom or the WebEx or whatever meetings work. Get comfortable with it. If you don't have a good mic, right? I'm not saying go out and buy an expensive microphone. Don't do that. But if you don't have an external microphone and your audio's choppy, borrow one from your school. Make sure the camera's set up that it's not like shooting up your nose, right? That you have a good angle, that you're dressed well, that you're professional. In other words, take it seriously, right? Don't halfway do it, because your opponents are not, and you want to make sure you have a good experience with this. I think you will be surprised at how intense online debating can be if you haven't done it before. It can be very much like the real experience, and the experience and the learning and the resume items are all exactly the same. So take it seriously and be 100% about it. The other thing I'd say is don't skimp on the reading on this. It's a massive topic, and it's going to involve a lot of just reading the bill itself, outlining it, making a little outline with a little cheat sheet of like where all the sections are and what they do. Right? Don't leave yourself in a position where you get caught flat-footed in a round against a good opponent that points out a section that you've never heard of. We regrettably just did not have time, even in a long video, to go through everything, right? But you need to do everything you can to wrap your brain around as much as possible. Now, are you going to be loaded for bear and ready to fight to the bottom on every single provision? No, nobody is. But the more aware you are and the more time you take to become familiar with these things, the more conversant you're going to sound and the better off you're going to be and the less likely to be ambushed you're going to be. So those are my thoughts.
Very similarly, I think you need to be on your A game. There is, of course, going to be some temptation like, oh, I'm at home, I can do this in the comfort of my own room, I can slack off a little bit. I promise you, your opponents are going to be very well prepared. So just because this is an online tournament, an online topic, doesn't at all mean that the competition is going to be any easier. So you need to prepare just as if this was any normal in-person tournament. Also, of course, since this is such a monstrous document, it's going to be very easy to let this debate get away from you, to make it very, very confusing and the water to be very muddy. So you need to be able to bring back what's important. Go back to that main metric, that main impact that matters the most, to make it very, very simple for your judge, because especially whenever we're at home, nobody wants to spend the time writing a 30-minute ballot. So make this very easy for your judge, get right out of the weeds and make it very, very simple for them.
Yeah, I mean, pull back, tell them what's important. That is as essential to this as knowing the statistics and the data, right? Focusing them on where they need to be and being persuasive. So, well, it's been a great, I think, a long first video, but we really appreciate you, tuning in, as it were. Wish you the best of luck out there on the, virtual tournament trail. Hopefully this has been useful to you. So we will see you back here again in November and December, as maybe we're moving a little bit back toward normalcy in the world. And until then, we'll just wish you the best of luck and close with our usual, which is work hard, have fun, and hail state.